Hello, good evening. I'm Mary Pavlou, and as president of Fabry International Network, and I'm delighted to invite you to our Fabry Moments webinar series for patients living with Fabry disease. This collaborative initiative between FIN and Sanofi aims to empower you with knowledge about disease monitoring and building your care. First of all, let's have our disclaimer. This program is being sponsored by Sanofi. The speakers are being compensated or receiving a honorarium from Sanofi in connection with this presentation. This content was jointly developed by us in FIN and Sanofi, and there is no, in any case, provide any medical advice, diagnosis, or treatment in these webinars. Any health information that there is contained is provided for general education purposes only. And if you have any further question about your health, you should consult your healthcare professional for your health or your treatment. As for my disclosures, I work with Sanofi, Amicus, Chiesi, and Takeda on several projects, always for educational and awareness purposes on behalf of FIN, and all fees go directly to FIN. And let me introduce our faculty for this first webinar, which is Your Monitoring Matters. We will have with us Professor Alberto Ortiz. Of course, everybody knows Alberto Ortiz. He's a nephrologist, and he will talk about how to monitor your kidneys. Then we will follow by Professor Maurizio Peroni. He is a cardiologist, and he will talk about monitoring your health, and followed by Professor Juan Polite. He's a neurologist, and he will talk about monitoring your nervous system. And we'll finalize this webinar with Professor Albina Novak, and she will talk about how important it is to monitoring your biomarkers.
Thank you very much, Mary, for your introduction, and let's go to the kidneys. I have some disclosures to make related my relationship with pharma companies. And these are the kidneys. We have two of them. They sit up there in the back behind other organs. And each of them has 1 million functional units, which are called nephrons, and they are composed by a filter to filter the blood, which is called the glomerulus, and by a tubule that modifies the filtrate to give rise to urine. When the kidneys are damaged, the filter does not work properly, and it allows sometimes blood, sometimes protein from the blood to be filtered and end up in the urine. So how do we know whether the kidney is damaged? Because there is albumin in urine. This is the main protein for blood. So albuminuria or proteinuria in urine. Eventually, the filters get clogged. They do not filter, they do not work, and kidney function, overall kidney function declines. And we measure kidney function in the clinic by the estimated glomerular filtration rate. How much does the kidney function? And this is assessed by a blood sample. We have recent guidelines from cardiology and nephrology societies that put the assessment of albuminuria at the same level as blood pressure, cholesterol, diabetes, and estimated glomerular filtration rate, that is kidney function, the ABCD approach to cardiovascular kidney metabolic health. So how do we assess kidney function? We already mentioned estimated glomerular filtration rate. So this is an equation that incorporates serum creatinine, that is a blood lab, sex, and age. And the nice thing, the beauty about this assessment is that the number, the value, roughly equates the percentage of remaining kidney function. In some cases, it may be advisable to actually measure the glomerular filtration rate when very precise assessment is needed, and your doctor will know whether this is required. This is more complex. It involves the administration of some molecule and then periodic blood assessments over several hours. So it's complex and only when needed. So the kidneys in Fabry disease, the Fabry disease causes progressive chronic kidney disease characterized by albuminuria, by proteinuria, so damage to the filter that allows albumin from the blood, proteins from the blood to be eliminated, excreted in urine. It has a long natural history of more or less 40 years until the kidneys are destroyed and kidney replacement is needed. So here again we see the glomerulus, and these cells up there, the podocytes, because they have these little feet, they have this little feet, the podocyte, sit out of the capillaries, preventing albumin and proteins from blood from eventually being filtered and ended up in urine. So here you have another vision of the podocyte. It's a yellow one. They have been artificially colored, but you can see that they have this small feet that interdigitate between them to prevent the loss of proteins or albumin in the urine. And they are terminally differentiated cells, such as neurons. They sit over there for years and years and years, so they can accumulate huge amounts of glycolipids. Here you see one glomerulus. It should be red because you should be able to see the red blood cells inside the glomerular capillaries. But in Fabry disease, podocytes, which sit outside the glomerular capillaries, are full of glycolipids, that is lipids, that is fat. Fat is white, and you can actually see the fat. And moreover, some glycolipids accumulated in Fabry disease, such as lyso-Gb3, will further damage the podocytes, just as high glucose levels do in diabetes. Okay, so this is the natural history of Fabry nephropathy. Similar to diabetic nephropathy, is a progressive proteinuric chronic kidney disease of metabolic origin. So as proteinuria and albuminuria goes up, kidney function, the estimated glomerular filtration rate goes down until kidney replacement therapy, if needed, if untreated at a mean age of 40 years. And this may progress asymptomatic until you need dialysis, so you need to do the labs: serum creatinine, urinary albumin, urinary protein. We can see here that as urinary protein losses increase over time, the rate of kidney function loss of glomerular filtration rate accelerates. It's like a snowball going down a mountain. So the time to act is as early as possible. Up here, when proteinuria is still normal, but you already may know that something's wrong because the loss of albumin in urine is already increased. So we have talked about proteinuria, about albuminuria. So normal urine has proteins mainly secreted by the tubules in order to protect us from infection, lithiasis, etc. And in normal urine, there is very little albumin. There is very little amounts of proteins filtered by glomeruli, because the mission of glomeruli is to filter the blood so as proteins are not lost into urine, so as albumin is not lost into urine. As the kidney gets injured, the number of tubules decreases and the number of tubular proteins in urine decreases too. And the amount of albumin increases. So at very early stages, proteinuria is still normal, but albuminuria is still high. This is why many guidelines recommend assessing albuminuria in urine. And eventually, both proteinuria and albuminuria will go up. Okay, so chronic kidney disease, what does it mean? And many people don't know it. They think it has to do with lumbar pain, back pain, but this is not the case. So a diagnosis of chronic kidney disease means an increased risk of dialysis, heart disease, or premature death. This is why you should take it seriously, diagnose it, and treat it as early as possible. So how we diagnose chronic kidney disease? When for longer than 3 months, this is chronic, either there is histological evidence of Fabry disease, of kidney disease, and in Fabry disease there is always histological evidence of kidney disease, or there is laboratory evidence of kidney disease, kidney injury, so the increase of albuminuria, or kidney function decreases, that is, glomerular filtration rate is lower. Please notice that you see the colors. This is like a traffic light. If you go to red, that's bad. So when you still have normal kidney function, you may already have moderately severe chronic kidney disease, high cardiovascular risk, if albumin losses are high. And if both kidney function decreases and albumin losses are high, you already have severe chronic kidney disease that is amenable to treatment. That's the good news. Okay, so what is the monitoring schedule recommendation? So if kidney function is normal, albuminuria is normal annually. If there is moderate CKD every 6 months, if there is severe CKD every 3 months. What should be assessed? So serum creatinine, blood test to estimate the kidney function, glomerular filtration rate, and urinary albumin creatinine ratio, that is a urinary test. What else? Well, during winter, your doctor may consider, depending on where you live, to assess vitamin D levels and supplement vitamin D levels because they depend on sun exposure or ingested of fortified foods. Sometimes doctors may consider to make a kidney biopsy because it's unclear to them whether kidney disease is caused by Fabry disease. Red flags for disease progression, when you should be concerned: when albuminuria goes up or proteinuria goes up, when kidney function, glomerular filtration rate goes down, and especially if both are going nastily. So albuminuria, proteinuria increasing and kidney function decreasing. Why monitor glomerular filtration rate? Because we all lose kidney function as we get older. We lose around 1 ml per min per year, so 1% of kidney function per year. So when kidney function is still normal, the therapeutic goal is to prevent glomerular filtration rate loss to maintain kidney function. When kidney function has already decreased, we want to prevent further progression of the loss of glomerular filtration rate, aiming to stabilize the glomerular filtration level, that is the kidney function. Eventually, when we reach kidney failure, kidneys are no longer able to support life. We are lucky that in the 21st century, we have kidney replacement therapy, that is either dialysis or preferentially, if possible, kidney transplantation. What's the role of nephrologists here? So nephrologists are kidney doctors, and they may help you whenever you develop chronic kidney disease, depending on the advice of your physicians. So early chronic kidney disease may be also cared for by additional physician specialties. And here we have the kidney monitoring within the wider view of Fabry disease monitoring. Every 3 to 6 months, depending on the severity, assess glomerular filtration rate, that is kidney function, albuminuria, and on proteinuria, depending on local and personal characteristics, to assess kidney injury. And at least annually, all of them, and in some cases, your physician may decide to measure glomerular filtration rate or to suggest a kidney biopsy or other assessments. Thank you very much for your attention.
Thank you, Mary, for the introduction, and thanks to Finn and Sanofi for inviting me to join this educational program for Fabry patients. The topic of my talk is cardiovascular monitoring, but I would like first to spend some minutes on the features of the cardiac involvement in Fabry disease. We know that we have two different phenotypes in Fabry disease: a classic phenotype starting in childhood with systemic manifestations, and then involvement of major organs in the fourth decade, while we have a non-classic phenotype in which the clinical manifestations present later on life and mainly affecting some organs, in usually the heart, with the main cardiac phenotype. In female patients, the clinical manifestations may be more heterogeneous due to skewed X chromosome inactivation and may range from an asymptomatic state to patients with severe clinical manifestations similar to those observed in male patients. The cardiac involvement is characterized by storage in all the cardiac structures, in all the cardiac cell types, not limited to the myocardium, but also affecting the conduction tissue, the cardiac valves, and the intramyocardial vessels. This involvement explains not just the pathophysiology of Fabry cardiomyopathy, but also the clinical manifestations. That include heart failure with preserved or reduced ejection fraction, cardiac conduction disturbances and arrhythmias, and also chest pain, with also some patients experiencing myocardial infarction with normal coronary arteries. We have many tools to assess the cardiac involvement in Fabry disease, to assess the patients with chest pain through PET, coronary angiography, but mostly CMR to assess the involvement of the myocardium. So now we are very clever in understanding the pathophysiology, and we are very good in assessing the cardiac damage in patients with Fabry cardiomyopathy. And we know that we have a progression of the damage in patients with Fabry disease in the heart, starting just with storage and then progressing to a second stage with inflammation and hypertrophy, and then an advanced stage with fibrosis and dysfunction. We have different pathophysiological mechanisms, and it is quite obvious that the efficacy of specific treatments is more important in these stages, in these early stages, why can be more limited in advanced stages, when other mechanisms, more important the storage, when other mechanisms become more important the storage, so like fibrosis or inflammation. As a consequence, it is very important to make an early diagnosis. In these stages, when we make a diagnosis in early stages, we have a high probability to prevent the main cardiac manifestations of Fabry disease and also to prevent the major clinical events. So early diagnosis, hopefully also through newborn screening or family screening, is very important to obtain the most efficacy from disease-specific therapies. It is important so to recognize all the very initial features that Fabry disease present as a cardiac involvement. In particular, we have cardiac imaging that is very helpful together with ECG in recognizing the early changes caused by the cardiac involvement in Fabry disease. We have ECG features, imaging features, and also some lab features. In this picture, you see that the signs and the symptoms may evolve over the progression of the disease. So in very early stages, it is very important to recognize some ECG features and some cardiac magnetic resonance features that we will discuss in a few minutes. It is also important to keep in mind that the main clinical manifestations of Fabry disease regarding the heart is the thickening of the cardiac walls. But we have many disorders that may cause thickening of the cardiac walls, and most of them are genetic disorders. And most of them have a specific treatment. We have specific therapies for Fabry, we have specific therapies for cardiac amyloidosis, but also now specific treatments for sarcomeric hypertrophic cardiomyopathy. So we have a lot of red flags in different settings. The age, for instance, is an important red flag because a huge hypertrophy in children may suggest a storage cardiomyopathy, while a huge hypertrophy in elderly patients is usually associated with amyloidosis. And so the pattern of inheritance, echocardiographic findings, CMR findings, and ECG changes. So recognizing these red flags, we usually are able to make a differential diagnosis and to suspect a specific disease. For Fabry disease, the red flags are very important and usually may raise the suspicion of Fabry disease in a physician with a cardiomyopathy mindset, expert in recognizing these specific features. You see here that we have ECG red flags like a short PQ interval, negative T waves in the inferolateral leads, but also some imaging features. In particular, cardiac magnetic resonance features like the presence of a low T1 of inferolateral late gadolinium enhancement are very important features, and we can say that cardiac magnetic resonance now is very important for a differential diagnosis of different causes of thickening of the cardiac walls. And this is well explained in this flowchart. In any patients with unexplained left ventricular hypertrophy, it is important to think to Fabry disease, to suspect Fabry disease, and look for systemic red flags or look for cardiac red flags when systemic red flags are not present. And one important cardiac red flags is the presence of low T1 at cardiac magnetic resonance. This feature may be the only sign that we can identify in our patients, and this feature is enough to suspect Fabry disease and to perform genetic testing in female patients or an enzymatic test in male patients. Of course, genetic testing is always mandatory to confirm the diagnosis. So, in every patient with unexplained left ventricular hypertrophy, the cardiologist should suspect Fabry disease. And in many cases, with non-invasive tools, which means ECG, echocardiography, and CMR, we are able in most patients to suspect a specific disease, as you see in these pictures with sarcomeric HCM, amyloidosis, and Fabry disease. Once we have suspected and then diagnosed Fabry disease, it is important to start treatment. Treatment of Fabry cardiomyopathy include, of course, Fabry disease-specific therapies, but also cardiological therapies and interventions that may be different in different stages and should be updated whenever the clinical picture evolves. If we start the treatment, the most important part is monitoring. Monitoring is essential to assess the efficacy of the treatment. Then we have the monitoring of treated Fabry disease patients, but it is also important to monitor the patients who receive the diagnosis and are not yet in treatment, because in these patients, monitoring is essential to identify signs and symptoms of cardiac involvement suggesting to start a disease-specific treatment. So the monitoring is very important in both untreated and treated patients. How do we monitor the cardiac involvement in Fabry disease? We have many tools, again, more or less are the same tools that we use for differential diagnosis, ECG, echocardiography, CMR, and biomarkers. You see that in early stages, it is very important to monitor the ECG changes, but also the myocardial features at cardiac magnetic resonance. LOT1 is very good for differential diagnosis and hopefully will become very important also to monitor the progression of the disease and the efficacy of Fabry disease-specific treatments. You see that over the progression of the disease, we have different changes that can be recognized in any diagnostic and monitoring tool. In advanced stages, also biomarkers can be very important. In particular, troponin is a biomarker of cardiac damage, particularly in the inflammatory and hypertrophy phase, and NT-proBNP is important to monitor the hemodynamic deterioration in patients with advanced cardiomyopathy. So it is very important to know from the physician side, but also from the patient side, that the monitoring of the cardiac involvement is multiparametric, including ECG, imaging tools, and biomarkers. More recently, it has become very useful, this staging system by echocardiography. This staging system in dividing and characterizing the patients in 4 stages: no cardiac involvement, hypertrophy, left atrium enlargement, and systolic dysfunction, may allow to predict the prognosis in terms of major cardiovascular events. So echocardiography is very accessible, is quite reproducible, and can be very important to predict the prognosis and also to say to the cardiologist how aggressive must be the treatment according to the stage. And you see in this picture that different stages may have a survival free from major cardiovascular events very different. Now we know that this staging system can be used also to monitor the patients, because over a period of 20 or 12 months, some patients may improve, as you see, moving from an advanced stage to a less advanced stage, and this is thanks to the treatment that they have started, while some patients may be not treated because in stage 0 may progress to stage 1 or 2, and this is a sign to start the specific treatment. So this staging system by echocardiography is very important for the prognostic stratification, but also to monitor the efficacy of specific treatment and cardiological treatments. We discussed about T1 at cardiac magnetic resonance, why it has become so important, because this very nice paper demonstrated that T1 is a reliable, non-invasive tool to assess the presence of storage in myocardial tissue. So far, is very good for differential diagnosis, but I think that in the future will become more and more important also to monitor the progression of the stabilization or improvement of the myocardial involvement allowed by specific therapies. So to summarize the disease, it is important to keep in mind that some tests should be performed every year, and these include ECG, echocardiography, Holter monitoring, and biomarkers. CMR can be very important and should be performed every 2-3 years according to the clinical evolution. If the patient is very stable and or has a significant improvement in the clinical picture, we can delay the interval between the baseline and follow-up CMR. While if the patient has some clinical deterioration or some changes at the ECG or some more arrhythmias, it is important to repeat the CMR even before 2 years to assess if there is any change in the myocardial tissue damage. It is important to remind for the patients, but also for the cardiologists, that if you decide to make a cardiac MRI in Fabry disease, this MRI should include T1 mapping and late gadolinium enhancement sequences to assess the presence of storage and also to assess the presence of fibrosis. And this is important at baseline and during the follow-up. We are also starting to use patient-reported outcome measures, because these are very important to provide the overall clinical picture of the patient. In addition to what we can see by imaging and ECG, it is important to assess how the treatment affects the overall burden of symptoms, how the treatment has improved the quality of life, the social life of the patient. So the patient-reported outcomes are very important and will become even more important in the future. In addition to the outcome reported by the patient, we can also monitor the cardiac damage and the cardiac evolution by some digital devices that can be implantable or wearable. You know very well that now we have a lot of devices that can assess the heartbeat, the heart rate, the blood pressure, oxygen saturation, and we have many devices that can be implanted and provide even more advanced information about the hemodynamic status. These tools are increasingly used also in Fabry disease and will be more and more important also with the introduction of artificial intelligence allowing to manage this huge amount of data. So in the very next future, I think that devices together with patient-reported outcomes will be more and more important to monitor the overall status of our patients, not just about the cardiac involvement, but to assess in a more holistic way the effects and the efficacy of treatments on Fabry disease patients. despite these improvements, the journey of the Fabry patients remains quite complicated, particularly in the first phases when the patient still has not received a diagnosis, but also in later stages for the access to treatment and to have an appropriate monitoring. Standardization of the monitoring of cardiac involvement is very important in order to compare different therapies and also for research. So networking is very important, and to provide an appropriate monitoring is important not just for the patient but also to improve our understanding of the treatment efficacy and the evolution of the cardiac damage. Thank you for your attention.
Thank you very much for the invitation to this meeting. Thank you to the Fabry International Network and Sanofi, because I had to talk about neurology, but mainly about monitoring related to my specialty. My name is Juan Politei. I'm an adult neurologist. I work with patients with Fabry disease during the last 23 years. And let me share with you some experiences that I've been collecting during these years. So here you have some disclosures. And this is a kind of index, because I would like to talk with you in the next 10 minutes, no more than 10 minutes, about when we talk about monitoring, when we do the monitor of our patient, what are we doing exactly? Do we have any chance to invent, to create something? No, the physicians, we agreed that some studies and some criteria for the management, for the treatment, for many other things are absolutely clear. So we gotta follow the guidelines, and I would like to share with you some of these guidelines. Then let me tell you, because sometimes you can talk with another person with Fabry disease, and you may listen, my physician requested me for a brain MRI, the other physician requested me for a specific neurophysiological test, trying to assess the capacity to feel the temperatures in my hands and feet. And you may say, well, but I did not receive that request. This is because today we have to customize, to personalize the studies, because it's not the same when we talk about the classic variant of Fabry disease or the late onset variant. It's not the same when we talk about a boy with Fabry disease or a woman at the age of 45 with the late onset variants. So it's important that you understand that not all patients may have to go for the same status. And then let me close this lecture talking about why we have to monitor and what are we trying to reach. We're trying to reach to the therapeutic goals. So let's start saying that when we talk about neurology, I'm not talking about the nerves, the cables, or the brain. Because when we do the follow-up, the neurologist with our patient, what we are paying attention is the brain, okay, the nerves, but what happened in the nerves, in the guts, in the bowels, in the abdomen? Because you know that most of the patient may have abdominal pain, abdominal cramps, or diarrhea, and this is the reason of the compromise of the small nerves. Also, some patients may have some hearing problems. And this is part of the neurology, attention to the feelings. This is why with specific questionnaires, because the presence of anxiety, the presence of depression could be there, and we have to manage this situation. When I said before that physicians, and mainly the neurologists, we have no chance to invent, is because we follow some rules. And these rules are written in the guidelines. So let me show you my part, my section, neurology. We want to see the brain of our patients. So after the age of 20, 21, 22, in males with Fabry disease, it's a good moment to see the brain with a brain MRI. I will explain later what is an MRI. In females, because you know that some female, or most of the female, they have a milder expression of the disease, we can wait for some years. Maybe we can start the brain MRI at the age of 30. Remember that we said that we have to pay attention to the nerves because of neuropathic pain, acroparesthesias, burning sensation. For that, at least once per year, we gotta go for some scales, questionnaires, surveys. In some patients, we may request a neurophysiological test, but in some super exceptional situation, you may listen about the skin biopsy. And the skin biopsy is not for the angiokeratoma, for the dermatology compromise. No, it's because you can do something in the skin biopsy. I will tell you in the next slide. So then the brain MRI, the brain imaging is not needed if you have no symptoms. And it's not needed once per year. Maybe you can do it every 3 or 4 years, okay? And when we talk about quality of life, this is very, very related with neurology. Again, questionnaires for pain, for gastrointestinal manifestation, for quality of life, okay? So let's talk in details about the test. Maybe a neurologist requested you to have a brain magnetic resonance. This is important. And as I told you before, not necessary every year, but the only way to see the brain is with the magnetic resonance. Because the tomography is not useful when you want to see the small vessels, the small arteries in your brain. So tomography is not the best choice. Let's move to the peripheral nervous system, the nerves. The electromyography is a neurophysiological test, and we need some needles, some electrical discharges. Fortunately, it's not needed in the 90% of the patient, okay? You don't need to go to the EMG, the electromyography. If you have the chance in your country and your physicians have the possibility to perform the quantitative sensory test, this is important. Because with this machine, you can see here in the middle part of the slide, you can apply some different temperatures, and you have to push a button when you feel that this impulse or stimulus is warm, is heat, or is cold. This is very important. When you have know this technique, you may go for simple tubes with water, with cold, warm, or heat water, and you have to distinguish between the different temperatures. Finally, in some places, and this is more academic. When I say academic, I'm talking about when we want to study something. You can go for the skin biopsy, and the physicians can count the number of pain receptors at the skin level, okay? Not necessary in most of the patients. Remember that I insist, and this could be for you sometimes a little bit heavy, boring, but for us it's very important because some of aspect of the disease, and as said before, depression, anxiety, pain, quality of life, we have no other tool. We have a specific questionnaires. So I'm just want to show you something as an example. We don't gonna go in deep with this scale, but you have to know that at least once per year, it's important for me to have the answers from a patient saying, I have a mild pain, moderate, severe, I feel depression, I feel anxiety, I feel abdominal pain. So these questionnaires are super important, okay? You gotta keep this in mind. So let's move to the bowel, to the intestine, to the gut. It's important, you know, that in some children with Fabry disease, abdominal pain, diarrhea could be a very, very severe manifestation. Of course, we have to rule out other conditions, irritable bowel syndrome, some intolerances. So in some patients, and again, it's super exceptional, we can go for an endoscopy, the upper or lower endoscopy. But what we have to go is for this. Take a look to the right part of the slide, questionnaires. We have a specific questionnaires. If you start a treatment And if I have no baseline examination of the gastrointestinal manifestation, I will never know that if you have an improvement or a stabilization or even a worsening of the symptoms. The ear, hearing problems, at least every 2 or 3 years, it's important to have an audiogram. Let's see the hearing function. Easy, nothing important. Remember what I said before, this is just a simple example. I'm showing you one boy with Fabry disease at the age of 9, one man at the age of 33, and one lady at the age of 22. But they have different phenotypes. What I'm showing you here in red are the important, the mandatory studies. But you can see that in some patients, there are some in red because you don't need it. Because you don't need it maybe because of the age, maybe because of the phenotype. So I'm not going in details about this, but you can see that in the males with the classic phenotype in the middle, in this case, we gotta go for all of the exams. We gotta pay attention to the brain, to the nerves, the heart, the kidney, the quality of life, and many other aspects of the disease. So what I'm trying to say is that it's not the same for all of the patients, okay? You may have more, or your friend with Fabry disease may have a less number of studies. So I'm reaching to the end. Why monitoring matters? It's super important. If you are just starting this journey with your physician, if you do not go for the studies, for the follow-up, for the monitoring, we will never know if you need or not need a specific treatment, okay? Should I start the treatment or not? Well, we need studies. We need to have the baseline status. When you start a specific treatment, no matter the name, we need to know if you reach to the therapeutic goals. A therapeutic goal is the objective. Try to stabilize the kidney, for example, the proteinuria in the kidney, try to stabilize the heart functioning, try to improve the neuropathic pain. This is super important, but we need the studies. And also, if you started a treatment and you did not reach to these objectives, you may need to change the treatment, okay? But the only way to decide this is having the studies. Sometimes you are receiving the specific therapy for Fabry disease, but you need to add what we call the adjunctive therapies, symptomatic therapies, trying to stabilize again the kidney, the nerves, the gastrointestinal manifestation. So, my dear friends, my dear colleagues, we need to follow the patients with regular monitoring. And this is the only way to have a control of the situation of the patient, and it is the best way to reach the therapeutic goals. So thank you very much for your attention, and I'm gonna be super happy to answer questions by emails, in person the next time in another meeting. Thank you very much.
Thank you very much for your kind introduction. My name is Albina Novak, and I'm working at the University Hospital Zurich, where I have been treating Fabry patients for the last 15 years. And I'm currently treating 140 Fabry patients in my hospital. And today I would like to speak about the monitoring of Fabry disease, and this is my disclosures. But first of all, I would like to emphasize that there are two clinical phenotypes in Fabry disease. First, we have the classic disease, classic Fabry disease, and second, a less severe later onset Fabry disease. In the classic Fabry disease, we have more severe Fabry gene mutations that lead to a very low enzyme activity. In these patients, we observe early symptoms. such as acroparesthesias, which means burning pains in hand and feet. We have hearing loss and tinnitus in younger patients. Patients cannot sweat when they are already in the childhood. For example, many children with the classic Fabry disease cannot participate in sports because they cannot sweat. They have abdominal pains, and they also can have the so-called angiokeratoma, which is a reddish, bluish spots on the skin. They also can have changes in their cornea, which can be seen by the ophthalmologist or by the eye doctor. This is in patients with the classic disease, and they can manifest these early symptoms. When the patients grow up, they increasingly develop a kidney disease, a heart disease, and they also can develop premature strokes of the brain. In the later onset disease of Fabry, we have less severe Fabry gene mutations, and they lead to somewhat more enzyme activity. Therefore, in these patients, we have a lack of early symptoms, such as burning pains in the limbs and so on. They have a normal childhood. However, once these patients grew adults, they can develop a heart disease, which means a muscle thickening of the heart. And this leads to a shortness of breath on exercises, and sometimes the pains in the breast. More rarely, patients with the later onset Fabry disease can develop only kidney disease, no heart disease, but this is much more rarely than the heart disease subtype. There are several biomarkers available to diagnose and to follow up Fabry disease. We have biomarkers that are typical for the organ damage, such as heart, kidney, and brain. And we have biomarkers that are specific for the for Fabry disease, that can specifically change the heart, the kidney, and have biomarkers in the blood which can be found almost only in Fabry disease. To the first type of biomarkers, which are biomarkers helping to assess the organ damage generally, we have biomarkers circulating in body fluids, and we also can have some technical tests or assessments. To the circulating biomarkers, we can have kidney markers showing the kidney damage, the so-called creatinine, and GFR. GFR represents the filter function of the kidney, which can decrease over time in Fabry disease patients. We also can measure the protein excretion in the urine, which can show the urine damage generally in Fabry disease, similarly to other diseases such as diabetes or other diseases. On the heart level, we can have troponin and NT-proBNP, which are unspecific markers of the heart damage. We also can have technical assessments such as ECG, which is a heart curve. We also can have imaging of heart and brain. We also can perform an ultrasound of the heart and kidney, which can show general damage of these respective organs. We can also have disease-specific biomarkers specific for Fabry disease, which can be found or measured in the blood. In this case, we can have lyso-Gb3. I will talk about these biomarkers a little bit more in advance in a minute. We also can have measured the enzyme activity in the white blood cells, as well as in the serum of the blood. And we also can judge on the severity of the Fabry gene mutation. The organ-specific Fabry typical signs on the technical assessment can also be seen on ECG, as well as on the imaging. For example, in the brain, we can see specific white matter lesions, which is specific for Fabry disease only, or almost only. We can have we can see a specific structural changes of the heart on the MRI, as well as on the heart ultrasound. Which bad guys are accumulating in the Fabry disease, in the tissues and in the blood? First of all, we can have GL3 or GB3. This guy has two names. And we can find the increasing storages of this metabolite in Fabry patients, specifically in the tissues and in the blood. What is special on the structure of this metabolite? We have three sugar heads. 1, 2, 3. And we have two fatty acid arms. This is one arm, and the second arm is R. This is replaced by this symbol because this arm can be very different. This can be longer than this one, this can be shorter than this one, and it can have a little bit different structure within the arm. So this is a bad guy with two arms. The next bad guy is lyso-GL3 or lyso-Gb3, also two names. And this metabolite has lost one of the both fatty acids. As you can see, this bad guy has only one arm. And with this one arm, it can particularly well swim in water. This is why this metabolite can be drawn and measured in blood and urine. And this is important to measure it because its concentration can be different in the classic Fabry disease compared to the late onset Fabry disease. As we have shown in this study, in the classic disease, in males and females, we had higher concentrations of lyso-Gb3 overall, and particularly in males, we had higher concentrations than in females in classic phenotype, as well as in the later onset phenotype. Lyso-Gb3 can be measured in blood and sent to the laboratory in tubes, but it also can be measured on dry blood spot cards. You only need to drop 1 drop of blood on this paper, filter paper, and you dry it for 2 hours, and you can send the sample in a paper envelope to the laboratory and actually obtain very reliable results. Why is lyso-Gb3, the bad guy with one arm, so important and so significant in the disease? It is also promoter of the disease itself, not just a biomarker. Lyso-Gb3 has been shown to promote the inflammation. It has been shown to increase the number and growth of smooth muscle cells in the heart. It promotes the enhancement of scarring tissue, and therefore lyso-Gb3 can be used as a biomarker of diagnosis and treatment monitoring of the important organ levels. such as kidney disease, heart disease, and brain, because it has been associated independently with the progression of the respective diseases. Lyso-Gb3 is also an important prognostic biomarker, which is associated with unfavorable events. In this study, we have divided Fabry patients into two groups. Group number one, these patients developed important clinical events within 18 months, such as kidney replacement therapy, new onset of atrial fibrillation, pacemaker implantation, myocardial infarction, or brain stroke, as well as death, whichever came first. In these patients, we had particularly high lyso-Gb3 levels. In patients who did not develop these events, lyso-Gb3 concentrations were much lower. When do we have to measure lyso-Gb3? To diagnose the disease and to monitor the disease progression. First of all, we have to measure lyso-Gb3 upon the diagnosis, and then every year at least once. Secondly, we have to measure lyso-Gb3 necessarily at the treatment initiation of the Fabry specific therapy at the baseline and afterwards every 6 months. Also, it is recommended to measure lyso-Gb3 once the patient is switched from one Fabry disease specific therapy to another. At baseline of switch and then every 6 months. And if we have stable patients who are receiving Fabry specific treatment, we usually measure lyso-Gb3 at baseline of treatment, of course, and every 6 months of the treatment. So what is the schedule of the biomarkers monitoring recommended by experts? We have to assess renal, cardiological, and neurological organs in Fabry disease. At first assessment, we of course have to conduct a brain MRI and to measure lyso-Gb3, as well as assess the quality of life of the patient. At every visit, we have to assess the blood pressure and to measure the cardiac rhythm. And every 3 months, we should monitor the kidney disease. You are measuring the filter function of the kidney and the protein excretion in the urine. Every 6 months, it is recommended to measure lyso-Gb3 and also to look at the quality of life of the patients. Every year, we usually measure the kidney markers, the heart markers, the pain evaluation. We measure lyso-Gb3, and every 2 to 3 years, experts recommend to perform a cardiac MRI and a brain MRI, which is an imaging of the heart and of the brain. So which biomarkers should we monitor as recommended by the experts? In terms of lyso-Gb3, it is recommended to measure lyso-Gb3 at first assessment. And afterwards, every 6 months, if the patient is treated with disease-specific therapy, or if a patient has a change or switch from one therapy to another therapy. And experts recommend to measure lyso-Gb3 every year, once a year, in the case the patient is not yet on disease-specific therapy. Thank you very much for your attention.
Please take a moment to take notes from this very important slide. This is your monitoring schedule summary. This is something that you can take a photo of it, and you can talk to your doctor about it, how you can schedule, or if you miss anything from your monitoring, you can talk with your physician about it and ask even question about it. I think this is the most important slide of the whole webinar at this point. And of course, this is our Fabry Moments curriculum. The first one will be on Thursday, 23rd of October from 5 to 6 Central European Summertime. And the next one will be on building your care. It will be on November 13th, 2025. Thursday again from 5 to 6 Central European Time, and we will talk about how to take care of your symptoms on your kidneys, your heart, your pain and your GI problems, and of course we will close off the second webinar with mental well-being with Nadia Ali. Don't forget to register. You can scan this QR code to register for the second webinar, which again will be on November 13th, 2025. And please, don't forget to scan this QR code at the end of the first webinar to complete the survey. It's very important for us so we can do better next time. Thank you very much.